I'd like to call the Mason County Board of Health regular meeting of May 28, 2019 to order. We have a lot of guests, so why don't we go ahead and do the introductions. Kevin, do you start?
Yeah, Kevin Schutte, Mason County Commissioner.
Sharon Truss, Mason County Commissioner.
Scott Hilburn, Mason General Hospital Board.
And Peggy Van Busker, Hospital District 2.
I got a text from about that space.
Before we have our approval of the agenda, I'd like to ask our Dr. Yu to come up for a moment, please. Right up here, so you can.
You're not going to throw an egg at me, are you?
No.
No, just a rotten tomato.
A proclamation at our board meeting today at the hospital. We went ahead and approved this, and this is now recognizing you in your service. I'd like to go ahead and read it to you. Okay. Whereas Dr. Diana Yu continually reminded our county health system that we should strive to improve difficult health outcomes. Whereas public health has been your passion for 13 years, and the citizens of Mason County are fortunate to have you share your talents with our community. Whereas you have been a solid supporter of Public Hospital District Number 1, your support to our staff is very much appreciated. Whereas even though you're no longer the health doctor for Mason County, your vision of ensuring conditions where everyone has the opportunity to be healthy will be a goal for us now and into tomorrow. Whereas you champion the phrase, we're the little county that could, which is so true. Now, therefore, the Commissioners of Public Hospital District Number 1 hereby designate Dr. Yu Appreciation Day to recognize you and recall the leadership you provided to our community.
I got it.
Okay.
I've been working out.
Okay.
So are we going to have a parade every year on May 28th? No, not quite.
Well,
Might be Memorial Day, but it's
Yeah.
not my day. Yeah. Thank you very much.
well, you deserve
Appreciate
it. Thank you.
Yeah.
Is there a motion to approve our agenda for today's meeting?
Need to amend it
Amended agenda?
for the group that's here.
Okay. Would you like to make a motion to amend the agenda?
Well, I
He
can't,
can't.
but I can say that we should add it to community health report.
Community health
The
report.
UW.
So done.
So I make a motion to approve the agenda with the added, I guess, presentation under community health report.
Okay, thank you. All in favor of amending the agenda, please signify by saying aye.
Aye.
Aye. Motion's carried. Anything else? Okay, approval of the minutes of March 26, 2019 and May 8th, 2019, the special meeting minutes. Have you had a chance to look at the meeting minutes?
I make a motion, we approve the March 26th meeting, and on the special meeting, we actually had executive session till 12:10 instead of 12. So I would like to amend that.
Okay, just for clarification purposes, because I'm not following you.
Okay,
Okay.
so then, shall we do them separately
Yeah,
then?
that'd be great.
I make a motion, we approve the March 26th meeting minutes.
Is there a second? All in favor, signify by saying aye.
Aye.
Aye, motion's carried. Thank you, Peggy. One more?
And I make a motion, we approve the minutes of the special meeting with the correction of that we came back from executive session at 12:10 instead of 12.
Okay, so noted.
I'll second that.
All in favor of approving the minutes as amended?
Aye.
Aye.
Motion's carried.
I apologize, may I ask a question on this? With that amendment, the last line does read that they reconvened and directed staff to conduct a reference check and adjourned at 12:15, so.
We did adjourn at 12:15, but we came back at 12:10.
It does say it reconvened, but you're just asking to put the time that you reconvened
Yes,
instead
because
of
it
reading that.
says executive session from 8:10 to noon, and it was really 8:10 to 12:10.
So you were still an executive? I'm
Yes.
sorry, I wasn't present that day. So
Yes.
you were still an executive at 12, okay.
Yeah.
Okay,
Thank you.
thank you for that clarification. We now have on the agenda an executive session to review qualifications of the health officer candidates.
Yes, so we need audience to leave, if we could, for just a few minutes here. And we need to say how.
10
minutes?
Mhm.
10 minutes it is. Okay, I'd like to call the Mason County Board of Health meeting back to order. Is there a motion, Peggy, that you'd like to go ahead and make
I make
relevant
a
to our executive
motion.
session?
I make a motion, we approve Dr. Stein for our health officer for Mason County.
I'll second.
Is there a second? Any further discussion?
Yeah, I would just say we had a number of really qualified applicants came forward as part of the selection process, and I think they interviewed very well, and look forward to working with our new health officer.
Good. Any other comments?
I was just very
Sure.
pleased to see 3 qualified people
Yes.
say they wanted to come to Mason County. I was
Mason
really
County.
tickled, so, yeah.
Yeah.
That's because you're the little county that.
Good, that's right.
I've been saying that for
Yeah.
years.
Okay.
Okay.
All in favor of approving the motion as submitted?
Hi.
Aye.
Opposed? We have a new health officer in Dr. Stein pending
I'll contact you this
HR.
afternoon. Okay.
involvement. Thank you.
Right.
Alex, would you like to
Okay.
share with us the environmental health?
Yes, so I've got a couple things to talk about. So I've got my monthly updates there for you guys to read. A couple items to talk about. We've got some changes coming. We're working on our sewage maintenance database and doing some updates to that will help improve transparency in that program, but also efficiency with our staff and doing maintenance mailings and reminders. And in doing that process, we've involved our on-site sewage advisory committee, and we've also been researching a new company, aside from the one that we currently have, that we're talking about switching to. So these are some big changes for our department. We use this program on a daily basis. Pretty much all our staff touch it. Building permits, complaints, sewage permits, water quality. There's a number of areas that this touches with environmental health. So we're pretty excited about it, whether we stay with the existing program or make this change to a new program. I think it'll be a very good benefit and change to our county and our program.
Good.
So,
Any questions?
yeah, any questions? Okay. The only other thing I wanted to note here, we have lost some funding, unfortunately, for our Group B water system program. Group Bs are a smaller public water system that's under local health jurisdiction rule. So bigger water systems, Group A, get regulated at the state level with Department of Health, and then these are kind of subsidized water systems that the local health jurisdiction regulates. So we've always received this $5,000 annually from TOH on this to help support our program, and that funding has been lost. So it's kind of, that program has been on our list of wishes to improve and go through the regulations and get some things updated. So this has kind of sparked that to the top of the list, and we're working on some updates there too. So.
How many wells fall into that size category?
So we're kind of unique in that we have a lot of Group B water systems for the county of our size. When you take, our comparable counties as far as population goes, they're generally ranging from 100 to 200 public Group B water systems that are active, and we're actually around over 500 Group B water systems, which is more comparable like Thurston County as far as water system count. So, and we're looking at about, I think it's 5,000 approved connections under those water systems too. So it's a big amount of citizens that are affected by these systems, and yeah, we want to make sure we're properly regulating them and making sure that they're providing safe drinking water for our citizens.
Is there a fee that we're charging now to do?
No, so that's the biggest part with our funding wise that we're differing from some of these other counties is they charge an annual operating fee, whereas right now we do not. There's some counties that have just recently adopted that. Kitsap's one of them. Northeast Tri just
Mm.
updated their water system regulations. So yeah, that's something we're considering, but right now I'm still doing this county survey to pull the information together and see what other counties are doing and get ideas on what we want to do and where we want to take it.
We did discuss it last week at the administrators meeting in Spokane, and one of the thoughts we had was, well, there's kind of two thoughts, and Matt Shantz from Northeast Tri kind of has, they're looking at trying to go a year and then see what happens over the course of a year with their fees, and just kind of let it coast a year and see what happens. Some of the other administrators were talking about using the foundational public health money, the 22 million, and I'll come back to that, as to help support some of the smaller jurisdictions in their Group B programs.
Yeah.
Because this certainly is water's foundational, so.
Yeah. And to clarify too, we do get permitting fees on Group Bs when we're reviewing like a new application or an upgrading system. But those permit fees, they cover our time involved with that specific permit. Where this money really came in handy is in regards to complaints, investigations, boil water advisories, these kind of things that come up in these public water systems, that activities that involve staff time, but we don't have any funding source for. So.
Any other comments, questions?
Okay, with that, I'll go to the letter I've got there for the on-site sewage advisory committee appointment. I'll go ahead and just read my letter for you guys. During the previous Board of Health meeting on March 26, I presented 4 applications for the open watershed position on the on-site sewage advisory committee. At that time, the board requested a recommendation from the committee. On April 3rd, on-site sewage advisory committee meeting, all 4 applications were presented and reviewed. In addition, the committee heard from each of the applicants who were present and held a vote. The final recommendation from the committee is Toby Taja Surratt. I again present all 4 applications for the board's review and appointment to this vacant position. In addition, I ask the board to designate a 1 or 3 year term for the position to achieve the staggered terms as we previously discussed. And the applications should be included with your guys' packets.
Yeah, I'm fine with what the board agreed on, but I would like to make it a 1-year term, mainly because I'm not that familiar with what they do, and I would like to see you bring back what the commission has
Mhm.
done and how it's run, because Randy brought up a good point about conflict of interest and the fact that this is kind of like people that do that job wasting themselves.
Mm-hmm.
And so I kind of like more information about what the committee does and how it runs. And so I would prefer just 1 year so that we can get a little more information.
Yeah, I can certainly do that. I can prepare some more information for our next meeting.
Do I have a second?
If that's
Was
a
that a
motion.
motion?
Yeah,
Was
that
that
was
a-
the motion, that I approve that they chose that person, because
Toby Surratt.
To appoint that
Yeah.
person for
For
1
1
year
year.
term, I'll
1
second.
year, not 3.
Is there a second?
I'll second.
Okay, all in favor?
Aye.
Signify by saying
Aye.
aye. Good?
Great. Thank you.
Doctor, you're up.
Okay, so, I've been coasting around here mainly because it's been fairly quiet, in Mason County when it comes to communicable diseases. And, so far, we have not, oh, that's not wood, this is wood. We have not had any real measles case. We've had a number of rule-outs. That means people who were suspected of having measles, so we still do all the work on following up and investigating and find out they do not. So it is a matter of time. We are fortunate that, our general, at least our children population, they're fairly well immunized in Mason County. So, and I have to say kudos to our pediatricians in town, Oakland Bay. They do a really good job of getting all the kids immunized. What we do not have or do not know are the adults. There's no real record of that, so there may be adults out there that may not be fully immunized. And what they're experiencing now in Seattle, King County, and Pierce County is when there have been exposures. The ones most currently that we started getting cases again, the majority of them are in adults. Some have had one vaccine, some, I think there was one person that had two, and then there was a lot of unknowns. So I think it behooves everybody to kind of know what their status is. And if you're not sure, it is pretty safe to go ahead and get the vaccine. So if somebody asks me, you know, I'm not sure I'm vaccinated against measles, just say, go down and see Peg, and she'll give you a shot.
So now, before it was said if you were born before
57.
that you don't have to
You don't
worry
have
about
to,
it.
yeah.
Because that's what I've been telling
Yes,
people.
that
So I
is,
didn't
that
wanna
is still
have it-
true. So the last major outbreak of measles in the country was in 1956.
Oh,
So the
okay.
assumption is that majority of the people were exposed, but if you lived in a mountain cabin in Wyoming,
Maybe
you
should-
may not have been exposed. So it is not 100%. It's statistically, that's what we do. So the last major outbreak was then, and so, you know, the vaccinations didn't actually start for another, you know, about
Mhm.
8 to 10 years. So, and then we had this fiasco in 1968 where the vaccines came out and they were being given improperly. So people were given vaccine on one arm and immunoglobulin on the other, basically negating. So you got it here, and then this shot over here killed the vaccine, and so the vaccine didn't work. So we figured all that out in the 1990s when we started getting outbreaks. So, and at that time there was a big push for adults to get vaccinated, and we did that. But you know, history does repeat itself, and now we're in 2019, and we're seeing adults get measles. We're seeing children get measles, and it's not a fun disease to have. It's not just a little rash. There are complications, and if we have enough cases, we can have deaths from it. So. Especially, and we've had, I think it's 8 cases this time. The last time there were 72 cases, and nationwide it's going to be a banner year for measles for the United States. So there's a lot of outbreaks in other parts of the United States as well. And for anyone who travels, like I'm going to the Philippines next week. It's endemic, so it's ongoing. And yes, I did have my measles when I was a little kid, and I was born before 57, so.
Close.
I was hit on both ends, so, yeah. So that's, one disease. So far we have not had any actual cases of measles, but again, you know, we could. The other is tuberculosis. We, historically will have like 1 case of active tuberculosis about every 3 years or so. We've been kind of overdue. We haven't had, I think we had one 2 years ago, right? Yeah. But we have not, so I guess we're still on par. So we have an active tuberculosis case that we're working on, and we also have another one that is a suspect. So to have 2 at one time is rare, and that's because 2 weeks ago I said to our nurse, we haven't had any. So I opened my mouth, and there it happens. So, but we are taking care of it, and doing contact investigation and doing all those things. So for folks who are not aware, tuberculosis is still a disease that is present. You know, in some cases, you know, it happens in folks who are born in other countries. But we also have plenty of people in this country that were born in this country that were exposed when they were children. And TB medications did not become invented until the 1960s. And so we didn't have treatment for it at all until then. So, you know, there are folks who are at risk, but it's a disease quite unlike measles. Measles is very easy to catch. If you are not immune to it, and I'm sitting here and I cough measles in the air, 90% of you are gonna get sick. With tuberculosis, we would have to be sitting in this room, put a lid on us, make us like breathe into each other for about 6 to 8 hours before maybe one of you would get infected. And just because you get infected does not necessarily mean you're gonna get sick. So when we find somebody has active disease that is contagious, we can still find out who they expose, identify people who become infected, and we have effective medication to prevent them from getting sick. So, you know, there's a lot of ways to handle tuberculosis, and it is something that we do in public health all the time. Even for us, it's, you know, once every 3 years. We still do it, we know how to do it, and hopefully we'll eliminate tuberculosis sometime in our near future, but it's gonna take a lot more work about finding all the people who are infected and treating them before they get sick. Right now, we're really good when people are sick and we identify that they have TB. We put them in isolation, we find all their contacts, and we treat them. And we treat the person who has disease and take care of it that way. But it's gonna take a little bit more work to find everybody in this country that has TB infection, because you know, our tools are not super great for screening for infection. But especially if you know that you've been exposed to TB, there is medication you can take to prevent you from getting sick in the future. So, any question? Yeah, in both of these cases, we don't have any concerns for the general public.
Good.
So, anything else? Right, I'm missing? Okay. That's it. That's my last health officer report.
How about that?
Yeah. No more diseases. Yeah.
And you leave on a good note, good positive note. With the
Right.
No,
My
yes.
nurse doesn't think so. But it's good experience.
Thank you, Doctor. Lydia, Community Health Report?
So you all received my manager's report.
Yes.
I'm gonna review that, but instead I wanna give my time to our group that's come to present. And I'm gonna introduce Bo Bakken, which most of you all know Bo.
Hi, guys.
Hey.
He started this whole thing, so I'm gonna let him explain and introduce our guest.
Yeah, so it was about 2 years ago, Dr. Yu and I were talking at the fire station, and we were talking about opioids and the impacts that it was having in our community, and how difficult things were out there. And one of the things she said to me is that, you know, if we're really gonna be successful, it's gotta be a community approach in how we respond. And so hopefully we've taken that mantle and run with it just a little bit. But we've done quite a bit of work, and I say we, I mean public health, and just everybody in Mason County's really come together. And we do have the loose formation with the Mason County Opioid Stakeholder Group, and I think I've seen most of you, if not all of you, there at some point. But one of the things that I wanted to have happen is to figure out what are next steps. We've done a lot of work, and we're doing, I think, a lot of tremendous work. But as far as the opioid response in Mason County, and the stakeholder group itself, what are some of those next steps? And so one of the things that came to my attention was a program through the University of Washington through their Evans School of Public Affairs. They have a student consulting lab where they take a few individuals and whatnot, and their job is for their essentially graduation projects, just go out and take on a public affairs and a public administrative type research project that's applied out in the community. And so I think a lot of you have seen these folks, but I'll introduce them, of course. But UW is, and you'll find out here in just a second, gave us their A team. I mean, this is the absolute phenomenal individuals, and they have been canvassing a lot of Mason County, talking to a lot of folks, gathering information, and also looking nationally as to what different people across the country are doing as far as this opioid epidemic. But we have Quinn Ziegler, we've got Zane Gustafson, Karen Lobos, and Colton Myers, and they are here to present their findings. They'll be wrapping up over the next 2 weeks their final report back to the stakeholder group, but they're here to present their draft findings so far. So, guys, take it away.
Thank you. How would you like us to set up?
Right over around the two on each side of the TV.
All right. Perfect. Great. Thank you for that introduction, Bo. So, yeah, so I just want to echo that. Thank you for having us here, and Bo kind of just touched on how we got involved with this. Like you said, we're graduate students at UW. We graduate in 2 weeks, so we're very excited about that.
Congratulations.
Thank you.
Can we hold you back?
So this is an adapted presentation from our report. Our report was specific to the opioid stakeholders group as a whole, of which Mason County Public Health is one part. But we've adapted this presentation for the Board of Health to focus specifically on Mason County Public Health role within the opioid stakeholders group. And so there's more analysis and more recommendations that we won't touch on today, but we've adapted that for the time that we have here. We'll be around to answer questions at the end of our presentation as well. So we started on this project back in December when Bo reached out, and we're talking with him about the difficulties with this problem in Mason County and how it's just very intersectional with a bunch of other health issues and other societal problems. And so with talking with Bo, we centered on this task. Our task was to develop realistic and achievable goals and strategies to address the epidemic in Mason County. And so these were kind of our guiding questions, and this is the structure of our presentation today. We're going to walk through a little bit of our research methodology, our analytical approach, and then ultimately get into our recommendations for Mason County Public Health specifically. And our project was specifically focused on how people can work together. It's more of a community stakeholder process than necessarily like a medical health research project. So this was our approach, and we did an academic literature review of how people address complex social problems, and through that we centered on the collective impact framework as the central idea, the leading framework for how to address societal problems like this. And we're going to get into what that means in just a minute. We also did some data collection and analysis, a lot of stakeholder interviews, and then also observations in the community. So generally, from the data that we were able to collect and analyze, things are improving over the past 2 years, especially. With regard to opioid deaths, the number of 10th graders using painkillers and whatnot. We do want to caution that this data was not as good as we could have hoped for. There was some incomplete pieces and pieces that we wish that we had access to that we just didn't have access to. So take this with a little bit of a grain of salt, but from the indicators that we were able to identify, things are improving. So we identified 18 stakeholders across Mason County, of which Mason County Public Health is one. We identified 3 main communication hubs, and that's Mason County Public Health, the people with lived experience, who are the people with opioid use disorder, in treatment, etc., and also the Mason County Superior Court. And so focusing in specifically on Mason County Public Health, Mason County Public Health is doing a lot with treatment providers. Really, they communicate with pretty much everyone on this list in some fashion or another. Even though that communication might not necessarily be coordination of services, they are at least in touch with everyone. And so, focusing on these bottom 3 bullet points, these are some of the things that the Public Health Department has been doing. They've been expanding naloxone training, connecting more people to treatment services, and expanding data collection, although data collection, as I mentioned, is still in its infancy. There's also been strong leadership from Bo, Lydia, and Abe in putting together the opioid stakeholders group and kind of getting people together and just talking, and that's a huge, huge first step. Mason County Public Health has been central to these response efforts so far. I really just want to emphasize that. And so now we're going to go into collective impact theory.
Thanks, Zane. Like Zane mentioned earlier, through our research, we identified the collective impact framework as the leading theory behind how agencies and organizations can collectively address large-scale complex social problems. This framework was developed by Mark Kramer and John Kanya, and it's been widely shared through the Stanford Social Innovation Review. You can look that up on your own time if you'd like. We found that jurisdictions across the country are specifically using this framework to specifically address opioid crises in their local context. The collective impact framework has 5 key conditions for implementation. And these 5 conditions are common agenda, shared measurement, mutually reinforcing activities, which are differentiated activities coordinated through a plan of action in order to ensure that the work being done by different organizations are being done to reach a agreed upon common goal. The 4th key condition is continuous communication. And lastly, creating and managing collective impact requires a separate organization to serve as a backbone support organization for the whole entire initiative. This backbone support organization is responsible for coordinating the efforts across all the participating agencies. And so in order to be able to do this, the backbone support organization conducts the following 6 activities, which are guiding vision and strategies, supporting aligned activities, establishing shared measurement practices, building public will, advancing policy, and mobilizing funding. Through our research, we learned that the expectation that collective impact or collaborative efforts can occur without a strong backbone support organization is actually one of the most frequent reasons why these efforts actually fail. So in order for this to be successful, there does need to be an institutionalized support infrastructure to guide and coordinate the collective impact effort if it is to be successful long term. We found that Mason County Public Health is already engaging in an informal manner in many of the activities of backbone support organizations. So for example, staff of Mason County Public Health have taken on really important data collection efforts and analysis efforts. These efforts have informed the response strategies of the opioid stakeholders groups here in Mason County. Staff have also shown the ability to work with multiple agencies in this area, and they're leading activities such as the treatment provider planning groups that are supporting both North and South Mason County. And finally, like Zane mentioned, Mason County Public Health staff are also spearheading grant funding efforts to make sure that these efforts have funding moving forward. We also learned through our research that this work takes place over 3 phases. Phase 1 focuses on initiating action, Phase 2 focuses on organizing for impact, and Phase 3 focuses on sustaining action and impact long term. So this is just like the quick SparkNotes version of the collective impact framework, and with that in mind, Quinn's going to talk about what the challenges the stakeholder group is facing and opportunities for collaboration.
Yeah. Thanks, Karen. So as Bo mentioned, we had the opportunity to talk to quite a few stakeholders here in Mason County. And we had, in those conversations, we identified several challenges that are facing the stakeholder group. Today, we're just going to focus on a select few of those challenges that we feel Mason County Public Health is well positioned to address, given its status as a leading agency in the stakeholder group. Now, while we ultimately recognize that these challenges are going to be difficult to overcome, we ultimately see them as opportunities for collaboration for stakeholders to work together to improve their response efforts. So the first challenge is that response planning and efforts are not uniform across Mason County. We heard from quite a few stakeholders about this divide between the north part of the county and the south part of the county. Now, this isn't necessarily an adversarial relationship, but it does appear to be inhibiting consistent communication, information sharing, and the pooling of resources. So when we're thinking about this challenge, what we're asking is, how can we ensure that stakeholders are communicating in a consistent and productive manner. Second, there's a shortage of funding, resources, and capacity to address the needs of the community. This was the most common challenge cited by the agencies and organizations we talked to. It's often the case that stakeholders want to sustain and even expand the programs and initiatives that they're working on, but simply don't have the time, staff, or resources to do it. In addition, we also heard about this challenge of human capacity. Opioid misuse is this incredibly complex and highly specific issues that often requires an extensive background and training to comprehensively address. And currently there's a shortage of that knowledge base here in Mason. So in terms of this challenge, we're thinking, how can stakeholders work together to overcome these capacity constraints that they face? Third, there's a lack of an established decision-making process and defined roles for participating agencies and organizations. So through our interview process and our research, we found that there's generally minimal stakeholder identification and participation in the 4 work groups that are underneath the stakeholder group in prevention, treatment, harm reduction, and data use. Now, this is not to say that good work isn't being done, but that often this work is occurring on an individual agency or organization basis rather than through collaborative efforts. We also heard quite a bit about how stakeholders are bringing really, really good and interesting ideas to the table, but there's no process or structure in place to decide of how to turn these ideas into action. And the final challenge we're going to talk about today is that data and information are not shared, analyzed, or communicated systematically and specifically to drive decision making. So as Zane mentioned, data around opioid misuse and data collection is really in its infancy. We heard from stakeholders that it's often been reactive rather than proactive. However, after talking with stakeholders, it became apparent to our research team that the agencies and organizations involved actually do collect quite a bit of information, whether that's qualitative or quantitative, but are not sharing that in a systematic way, and the information that is being shared is often anecdotal. However, I do want to say that the folks we talked to did recognize the importance of data. This is not only for providing better services, but also sustaining response efforts, evaluating whether these efforts are being effective, and also making these organizations more competitive for grant funding, which often requires some sort of data reporting component. So with those in mind, and given that many of these challenges focus on how to successfully implement coordination and collaboration across stakeholders, we ask, what can Mason County Public Health do as an essential member of the stakeholder group to address these challenges? So first, we're recommending that Mason County Public Health's role as the leading and coordinating agency of the stakeholder group be formalized. As Karen mentioned, having a backbone organization to coordinate and provide a structure for consistent communication is essential to the success of this group. And this recommendation is really about recognizing the work that Mason County Public Health has done in establishing it as the lead agency to provide a structure to sustain these response efforts. The key takeaway here is to ensure that stakeholders are accountable to a particular organization rather than simply a specific set of individuals. We're recommending that as part of this process, Mason County Public Health have the authority to guide and moderate decision-making within the stakeholder group. Our research suggests that this is largely already happening, but by formalizing Mason County Public Health's role, it makes explicit the stakeholder acknowledgement of how programs and initiatives are being coordinated across agencies and organizations to streamline this process. We believe Mason County Public Health is the best candidate for this role. As Karen mentioned, they're already doing much of the work of a backbone organization. In addition, this is a public health issue, and they are serving as a central communication hub on this issue. In addition, we'd recommend that Mason County Public Health formalize communication and information sharing agreements with participating agencies and organizations and be active leaders of the 4 work groups that I mentioned earlier, which Colin will go into more detail briefly. Second, we're recommending expanding and formalizing outcome monitoring. So as we discussed, outcome monitoring is essential to evaluate whether progress is being made, sustaining support for these efforts, making you more competitive for funding. And as part of our report, we're recommending a specific set of metrics that were based on the Washington State Opioid Response Plan, but expand those metrics to provide a more nuanced and comprehensive look at this issue. For this recommendation, Mason County Public Health would be responsible for obtaining and collecting the needed data, analyzing it, and reporting it out, which we recognize will require additional staff time, training, and resources to ultimately achieve. However, all the data that we're recommending we find is either currently publicly available or being collected through a participating agency or organization. So this recommendation is really aimed to provide a structure to use this data in a way consistently to guide the decision making of the stakeholder group. And with that, I'll turn it over to Colton, who will walk you through the rest of our recommendations.
Thank you, Quinn. So for our next recommendation, we had defining roles and responsibilities to promote accountability. This primarily is relating to the work groups that are already in formation. So part of the key components of this are to update the memorandums of understanding to reflect formalized communication structure and the common vision and mission. We recognize that Mason County Public Health already had some form of MOU in place, but that, as Quinn touched upon earlier, a lot of the information sharing and communication among the work groups themselves are done in a very informal fashion. And so this would really help to establish agency expectation and shared measurement practices through data collection and sharing agreements. Again, also, we would like Mason County Public Health staff to lead each work group. This sort of goes in tandem with what we mentioned with Mason County Public Health's role being identified as a backbone organization and help establish accountability across each work group. Prevention, treatment, and harm reduction work groups would meet monthly. Again, this would sort of be to formalize the informal meeting structure, and we would anticipate that Mason County Public Health would help to coordinate to ensure that there are consistent meetings. Each organization would designate a communication contact lead. There's a lot of organizations that show up to these meetings, and sometimes they have multiple members. And so this would help to keep, Mason County Public Health would be able to keep contact information for a designee of an organization so that that is more formalized, it's easier to access. And then lastly, monitoring communication frequency between organizations. And this is just to ensure consistent response across work groups and stakeholder organizations. Our next recommendation was that the Mason County Opioid Stakeholder Group should create an advocacy work group. And there's two goals in mind that this advocacy work group would accomplish. One is to identify and advance policy that would help to improve response efforts. And the second is to identify and advocate for sustainable funding sources. We recognize, again, a lot of the funding sources comes either through grants that Mason County Public Health does a lot of the groundwork for, and also through the treatment sales tax. But for example, one of our thought processes were getting the state legislature involved. Something that we identified was there wasn't a lot of interaction from our state representatives. I'm a member of the 35th district. So recognizing being able to leverage that with the state representatives, being able to advocate for Mason County and the work that's being done already. A thought process of this, again, is that Mason County Public Health should have a representative. The opioid epidemic, as been mentioned, is a public health issue. So who would be better suited to understand policies that are impacting public health, either that are currently hindering the process or may be able to help improve the process. And also, as mentioned, Mason County Public Health does a lot of the grant work, so this would help to ease the burden and reliance on grant funding in general. Our next recommendation was to adopt culturally competent practices. Our definition of this was the process of communicating with audiences from diverse geographic, ethnic, racial, cultural, economic, social, and linguistic backgrounds. And there's two key components of this. The first was to identify and eliminate service and participation disparities for people of diverse racial, ethnic, and linguistic populations. Mason County is growing in its diversity. There's a sizable Hispanic Latino population that's growing. There's also 2 tribes that are a part of this county. And some of the thought process of this could include collecting and analyzing data beyond age and gender, such as including race and ethnicity, sexual orientation, gender identity, housing status, and or income characteristics. This would really help to further identify who is or who is not at risk. And then the second component, conducting outreach and ensuring everyone has a seat at the table. And predominantly with this would be Mason County Public Health's role would effectively be to hold accountability for reporting on culturally competent practices. And this would generally be accomplished through the check-ins during the work group meetings. So what's next? As Karen identified earlier, the collective impact model takes place over 3 phases. our analysis indicated that the Mason County Opioid Stakeholder Group is finishing out of phase 1 and beginning to shift into phase 2. Our recommendations are ultimately designed to help build a strong foundation and help shift into phase 2, and also to be able to build a strong foundation into phase 3 to be able to coordinate resources, programs, and policy development that can comprehensively and collectively address opioid misuse. And with that, that's our SparkNotes version of our presentation.
Thank you so much.
Thank you.
Good job.
So we're happy to answer any questions and flip through the slides as people, as you want.
Will we have the opportunity to get the copy of the slide deck?
Sure.
Absolutely.
Good. If you would, I'd like to share it with the folks at Mason General. Excellent job. It goes ahead and shows the good work of Lydia and Bo and the progress that we're making. As we go into the next step, do we have the financial resources to be able to go ahead and support this initiative?
I think I was looking at that, you know, I was counting staff in the resources that Mason County Public Health would need to be able to, I mean, we already do a lot of that work, but we have a limited number of staff. So, I mean, it would be the Board of Health's direction to have Mason County Public Health take it on and to serve in that role. When we started this, it was really a lot of collaborative community effort, because bringing people together in the initiation phase is what was the most important, and to not put ourselves out as the leader, as the person on top directing everybody. It was more of an everybody come to the table and let's gather. So this is a great analysis of how far we've come now that we've gone through phase 1, now phase 2, and it's a logical analysis, because yes, we are doing a lot of that backbone support, but we also need to recognize the limitations of just staff, and where the direction is going to have to come from the board that says, yes, you guys need to do this, and then, you know, Dave and Lydia are going to have to figure out how.
Part of what we're working on at the state level is to look at some of the language the legislature has used in describing the problem as opioid, when what we're really talking about anymore is substance abuse, because a lot of our addiction is shifting from opioids to meth, or actually I should say shifting back to meth. So when legislation comes out aimed at opioids specifically, sometimes it's difficult to make that jump across to other substances. So we're trying to get that language loosened up in statute.
We're always good at finagling.
Yeah.
And
that's what public health is.
I appreciate your presentation, guys, and your report. It's 100 pages long, by the way, folks, so it's really good if you want to. But I appreciate it. Just clarified things a lot for us. My staff is really good at collective impact. We studied it for many, many years. I'd love to learn more about how to get the community on board to do collective impact, because that has always been our struggle. But we are familiar with the collective impact model and kind of have used that. As far as staffing, we do have great staff, and as you were naming off the different groups, I thought, oh, that person would handle that one and that would handle that. True, our funding at this point. We're trying to sustain our staff, who will disappear if we don't get the grant we just asked for, or we just applied for, that we'll hear about in a few months. But that would help sustain us for a few more years till we could get more things in place. So we are looking at ways to sustain the current staff that we brought on through this project, or these projects. And I think there are other resources that are available to us. I kind of appreciate that. So the initiation action, what the other piece that you mentioned it in your report, so maybe you could add something to it about it, is how this is a model to deal with the opioid, but it really can transfer over to any health issue that's going on, public health issue that's going on in the community, and we have a number of them. And so that's where our Mason County Health Coalition could be stepping in and thinking about how to use what they've given us here to be able to see the steps that we need to do to deal with some of the other issues in the county. So,
oh, go ahead.
No.
I was going to say, no, thank you for that. One of the things in talking about funding, obviously we didn't look at the finances really closely. But when we were constructing the recommendations, we were very cognizant of funding being a huge issue. And so when we were putting this together, we were trying to figure out a way, like what is the best bang for your buck, essentially, of what are the most essential functions of the backbone organization, to really pare it down to what is really would be most necessary. And so, yeah, we do recognize that it would require more funding.
Randy?
I'm always the one that's a little bit off and different, so I'm gonna throw something else out here for you on this. I've been involved for quite a while through this process, and I've watched how it started. The Board of Health and Dr. Yu did start aspects of it, but there's some pieces missing here that I don't know that you've seen, that I see a little different. I want to show you. It's an old expression, great issues, great leaders don't make great issues, but great issues make great leaders. And from them, you know, a great example, Martin Luther King. The issues brought him forward, but he was the person that needed to lead at that point. Others have tried over and over and over again, and they've never been able to do it. In this particular situation, there was great things that was done by our Board of Health that brought these things forward, but it wasn't until one person grabbed a hold of it that it changed the whole dynamic of it. And that's the piece that's missing on here. Bo Bakken, when he grabbed a hold of it, in every organization, it's 2 or 3 people that do all the work. It's just the way it is. You can have 100 people on your board. There's a piece missing here. That has been the glue that held all these pieces together. These things were happening all over. It wasn't until this one person grabbed on did this all start to become what you see today. That other expression is, how do you tell whether a person's a leader or not? The answer is actually as simple as this: well, you follow him. And everybody is following him. So therefore, if that's taken out of the equation, can it continue in the direction that it's going? Is my only point I'm trying to make, because there are great people in our staff that are doing incredible things, that have been for a long time. That first one that you put together was phenomenal that we had here, and we started a little group out of it that did some incredible things. But again, it's when one person changed everything that it became as big as it is, and now it's almost out of control. It's so big. So I just wanted to throw that, well, in a good thing, in a good way. I just wanted to throw that out for you to recognize that sometimes those little pieces, even though we'd like to put the Board of Health in charge of it,
Yeah.
will the people still follow? Or is it like Martin Luther King, where others will try to stand in his shoes, and it just doesn't happen that way?
Absolutely, and I completely agree with that. That was one of our concerns about this, is recognizing that, you know, if Bo goes to some other organization or moves out of the county.
Yeah.
No, it's purely a hypothetical.
He's part of us.
Purely a hypothetical.
Late night weekend conversation.
You know,
Yeah, we'll give him a desk at Public Health.
Yeah,
How's that?
is how do we make sure that the organization continues? And so that was why we wanted Mason County Public Health to be the backbone organization and to really formalize that role. Will people continue to follow? We can't. There's no way to know that, and you know, unless there's another visionary leader, right? But I think through our recommendation of like formalizing these structures and getting people on the same vision and mission, that's about as good as you can do to try to address that problem that you really correctly pointed out.
Yeah, I would add to that too. We did sort of evaluate in our report the impact that people like Bo and Lydia and Abe have had. And again, our report was mainly on the basis of how do we institutionalize this if one of them leaves? How do we make a cultural, foundation that doesn't crumble if the person that the community is following steps away? And so that's mainly what our recommendations were formed on, was how do we solidify this in a way that it creates an organizational structure that can survive beyond one person.
Well, it's great work. It really is. So
Yeah.
please don't misunderstand me.
No,
Proud of what you put
no,
together.
your question is
It's
great.
good, it's a good comment. Kevin, Sharon, any comments from either of the other?
Yeah, I would
commissioners?
just echo everybody's gratitude and praise for the work that you've done here. I'm anxious and excited to see more of the report when it gets finalized. And I think we do. I think we have a tremendous public health staff, that is ready to kind of be the standard bearer for this work going forward. And I think I look at the progress that we've made with Chief Bakken, and I think we've created a team of teams in some ways, and I think it's probably this is going to be a conversation that's ongoing at our stakeholder meetings. I don't really see those stakeholder meetings and that group going away, but I think there's a tremendous amount that we can gain from having sort of a clearinghouse, that everybody in the community can continue to turn to, and that makes the most sense to be public health, because I think they have the skills, background, and abilities to really continue to organize and affect change in the community at that level. So I don't see this as a moving away from what Chief Bakken has done. I think he's going to continue to be a critical. First off, he's a funding partner, so we're married in that sense, and we're happy about that and grateful for that, But I think this is an exciting opportunity for us, to continue to lead the conversation at the public health level, and I think we have some great people in place to do that.
I know when I go out in the public, I brag about the group that Mason County has put together. No other county can really step up and lead like Mason County is leading. And we have great people. Your presentation was amazing. It was very good. Thank you.
They were handing out resumes at the end.
What are you specializing in, each one of you?
Local level government.
Wow.
I'm energy policy. It's
Ah.
completely different, but this has been
Criminal justice.
Social policy, particularly around mental health, child well-being.
What a great combination.
Wow, a little bit of everything here, good.
I think one of the things that I'm most interested in too is your continued thoughts. As this kind of winds down for you, but your continued thoughts on capacity building in the community, and what other opportunities and venues we should be plugging our community leaders into to continue to help make that happen in our community. Whether it's substance abuse or it's housing or nonprofit leadership, I think that idea of capacity building in organizations is critical for counties of our size and our resources. So if you come across additional resources or opportunities that we could plug folks into through UW or other organizations, please continue to keep us in mind for that.
For you in local government, get used to that. Everybody's going to ask you for money.
And then just to say on the grant that we just wrote, so going forward, we did it collaboratively with 4 main organizations that have stuck together throughout this process, and one of them is North Mason Regional Fire Authority, which gives us all our EMS and all our emergency people, and then Mason General Hospital is the other partner that's gone in, and then we have our federally qualified health clinic, Peninsula Community Health Services, and then Mason County Public Health. So us 4 have kind of joined together that we're going to continue to work as a team, as agencies that are really strong in keeping moving forward in this. So we're not planning on losing any of them.
Haha, nobody else gets to retire.
Well, thank you so much.
Yes.
Thank you, good job.
It's been a pleasure.
Congratulations on graduation.
We will say if anyone would like to speak with us individually, one-on-one after the meeting, we'll hang around outside if you'd like to take that opportunity.
Great. Thank you.
Thanks, guys.
Okay, Dave, what's next?
Well, oh, tons. No, I'll keep it really short after that. That was really good. Been a busy couple months. We did have all staff in April. We used, Commissioner Trask was there, we used the Spokane Dying, or not Spokane, Seattle is Dying. I just read an article about Spokane is Dying too. But Seattle is Dying, as we watched that through, just to use that as a conversation starting point. You know, realizing the biases within the documentary, and then moving forward is that, you know, what can we as Mason County Community Services do with the tools that are in our toolbox. So we had a really good discussion with staff. It went probably another hour and a half discussion after the video. So we had it was a really good day, very productive, and a good exercise for staff to see that building and planning and public health really all have the same goals. We just have different pieces of that pie and trying to put it all together. So we're uniquely situated in a way that Seattle or Thurston or any of the bigger cities aren't, in that we have a lot of the pieces we need to solve problems under the same roof, which is like kind of ideal. So that went very well. Staff, I think liked the day. It went very well, I think. I was in Washington, D.C. Last week before last, working with the Puget Sound Partnership, talking about funding for Puget Sound, especially the National Estuary Program. And we just got word at the end of last week that the NEP looks like not only is it going to be reauthorized, but they're going to add, I think, going to go from 28 million, I think, to 33 million. So that's some improvement, and that's coming from the feds. That money will come down to ecology, then over to DOH, and then we will have to reapply over the summer to make sure that we apply for our shellfish beds. Part of what my role was, because I was invited to go by Department of Health, and so what do you want me to say? And I talked to some of the points of friction, people who don't necessarily find value in what we're doing in Puget Sound, especially from maybe other states. And my point was, if public health is funded and we can literally go upstream, you can save money downstream. So if we're actually out there doing those things that, you know, Alex is working on, trying to improve water quality, water quantity, all those sorts of things, before it gets to the sound, we can save dollars, you know, in the downstream end, and not having to correct things. We've corrected them before they get there. So that was a good selling point to some people that may have had some reservations. And then just this morning, we had a meeting with the hospital board and talked about many of the things that they covered here, about having you know, that group impact on things, and then having champions that can step up and lead forward. You know, even though we may be a great backbone organization for the community forum that is going to replace Mason Matters, it's really helpful if we have that champion within the medical field that says, yeah, I want to take this and run with it. And it really adds a layer of credibility and drive that will help. So we're working on that. I appreciate being able to come in and talk to the board today. That was great. It was really helpful.
Good presentation.
Yeah, it was a good presentation. And it was great to see you guys have the same IT problems. Yes, it's just the same as we do.
Yeah, just money, right?
It's just money. It's just money, people. Yeah, who knew? We do have SmartGov is more and more the bugs are getting out of it, and we're able to basically cross-reference between public health and building and planning and my office and code enforcement. We're all able to look at everybody else's stuff. So that is coming around and being more successful all the time. Actually, we're starting to weed out and take some of the pieces that we don't use, set them aside, so it's not cluttering the work that we are doing, so that's helping as well. We already talked about Group Bs, and the public health, we did pass the Foundational Public Health Services bill this year, which was separate from the funding bill. So that piece, we were very deliberate in getting that passed as making sure that Foundational Public Health was written into code and defined, and will go forward on its as a standalone without funding attached, because every time you attach funding to it, then it becomes a point of contention. So we did ask the governor for $296 million at the beginning of the year, and the governor's office came back with an offer of $22 million, left off a zero there. And then we asked the legislature for $100 million, and they came back with an offer of $22 million. So we're sticking pretty much with the $22 million and moving forward with that. We did have a big meeting with WSAFO last week to really look at that $22 million and how does that come down to local governments, and quite a raucous discussion. So as chair, I finally just said, all right, let's do one piece at a time. Can we all agree on what we can support for tribes? And we get that piece through. And can we all agree on piece after piece? And what we agreed upon was around our $14 million allocation that really backs up with what we've been doing the last 2 years. So of that, $9 million is to local health jurisdictions, $2 million to Department of Health, specifically to Public Health Lab, which has been extremely busy since we've had measles outbreaks. So that has been just a huge, huge thing. So $1.2 million to the tribes, which was a piece that had not been included before. We agreed that that was a good thing to do. The piece that we did not agree, $3 million to Seattle-King County. So just as a background, Seattle-King went to the legislature last year and got $3 million to do for some Foundational Public Health work around the disease load that they're carrying up north. And they really do have quite a high disease load. So there is some consideration. Do we distribute that money across everybody, or do we keep it in Seattle? And we finally had an agreement. We need to keep that money in Seattle, keep Seattle doing that work in those high disease locations. So that's going to move forward. Now that brings us down to about 5.8 million or 6.8 million, depending on how we do things. Discussion next week, and that's when we'll probably get cranky, is at the end of next week as we start to parse out what does that look like, that new money of $5.8 million, how does that get distributed out to local public health or DOH or State Board of Health. So the way that the legislation set this up is that when we get funding for public health, Foundation Public Health, it comes to Office of Finance and Management. Then the three partners of Public Health and Department of Health and State Board of Health have to agree. We have to have concurrence on how that money is spent. And then we go to OFM and say we have concurrence and the money is released. If we don't have concurrence, it goes back to the state. So it's a really big carrot and a really big hammer in there as well for us to make sure that we sit down and have open discussions and have agreement on how we address public health as a system. So I think that's a huge success in the way we set it up. The tribes are a separate thing entirely because they have a government-to-government relationship, and that's going to be handled through Department of Health. So WSAFO will be kind of out of that business. So next week we'll have the big discussions on the 5.8 million and what do we want to do as far as shared services. One of the things we've talked about is how would we possibly in this region share a health officer, and then maybe have a deputy health officer that would be like the traveling salesman of health officers that would work at the smaller counties. So those are the things we're going to explore with that 5.8 million. That peanut butter doesn't get spread very thick though. When you slice it out across the whole population over 2 years, that's about 43 cents per person per year. So it's not a huge investment in public health, but it is a permanent investment in public health in that we don't have to go back year after year with this particular 22 million. It will be in the budget. It's going to be in the continuing budget for DOH. So I think that's been probably one of the biggest successes that we've had in public health, and in really quite a long time. It's really probably since I've been in public health, is to make sure that we have concurrence between DOH, State Board of Health, and local public health as a system, and start coming up with some very clearly defined principles that guide the whole system, not just individual pockets. So it's a new process, and it's going to be a bumpy ride for a while. We do have to formalize the steering committee and who is on that steering committee and how decisions are made. So at this point, it's a little bit cumbersome in that the steering committee will make recommendations. They will go back to the WSAFA board, go back to DOH, go to State Board of Health, get concurrence or get agreement, and then goes back to the steering committee, then move forward to OFM. So we hope to streamline that process a little bit, but it may not for a while. So I think for me, that's about it. I've just been working a lot with finances and bringing money to the department and keeping things, running forward. A lot of policy work. We did take in fact, we're going to have a hearing, I think, next week on the 55-foot height limit. One of the barriers to getting affordable housing is that it's difficult to get a development to pan out, to pencil out with the 35-foot height limit. So what we're proposing is raising the height limit inside the urban growth areas to 55 feet, allows developers a lot more flexibility on how you develop on the same footprint and possibly work towards some more affordable housing. One of my concerns has been that as we go into this next 6 months and the BHOs phase out and the MCOs, become that part that drives that coordination of services, there's nobody who's doing infrastructure. As it's outlined now, there is no mechanism by which we build more beds. So that's a big concern of mine, is that we may have great coordinated entry, but no place to put people. So let's start figuring out what those barriers are and picking them off one at a time. So, and again, that's where Mason County Community Services, as the bigger organization, has the ability to start bringing people in and picking those off. So that's kind of where we're at.
Good report. Any
Thanks.
questions for Dave? Lydia, I need to get back to you. Anything more in your report after you, Dub? Okay. Great.
Other than reminding everybody that can come to tomorrow to Dr. Yu's retirement party over at the Civic Center from 4 to 6.
Bring cash.
I want to see you dance.
Bring cash.
And dance.
I'll have the boombox
She'll be on a fixed income now, so bring cash.
Next time on the agenda is other business and board discussion. Anything we missed in today's meeting that we need to hash over some more, discuss? Okay, moving on to public comment. I see we have a couple visitors. Like, anything you'd like to go ahead and? Nope. Okay.
Oh, come on.
Oh, come on.
I was trying to get Dale to say something, but he wouldn't. So, I also am with the University of Washington. So, I had to be here to support fellow Huskies. The university has an office, as many of you know, here in Shelton, and we've been here for the last 30 years working on water quality issues. So, what I would like to remind everybody is the State of the Oyster study is out and about. And this is where homeowners can have their shellfish tested to see if it's got bacteria in it, both fecal coliform bacteria and Vibrio perihemolyticus, the one that makes you really sick that's naturally occurring. At the same time, we also have the homeowners be able to test their wells to see if they've got total bacteria, E. coli in particular, but also they can test for lead or any of the other components that they're concerned about. Once Mason County's lab went down and had to go to the Thurston County route, it was kind of difficult for seasonal residents, and so we started offering this as well. So we've been doing the State of the Oyster study since 1987, and we have a lot of people that participate. And I'm happy to say all of the Mason County samples that were taken last week showed up well. They all had fecal coliform, but none of them were of an alarming level. So that's fabulous. And it's not just in Mason County, it's throughout the entire Salish Sea. Our most northern person comes in from Bellingham Bay and provides samples, and we cover most of the counties. It just happens to be the locations for drop-off are here. So it's kind of interesting to see, but it's a way for homeowners to be able to check and see, because the state maps that we have are really only on commercial beaches and on those public recreational beaches. So if they're worried about their clams and oysters in front of their house, this is their way to check. So the other thing that's happening right now is we've got a resurgence on our marina program. And so a lot of you know that our marinas have boat pump out stations and are part of Clean Marina program, which is great. And they also have fueling, and Sea Grant, part of the university, partnered with a lot of others to develop a manual. And what we're finding is a lot of the commercial growers are using this manual as well, because it's got some great best management practices in it for them, for both fueling and for boat haul out, for, you know, all of those sorts of things. And they're using it as part of their permit for the Army Corps and through the State Department of Health as well, addending it to it. So we've got these available if anybody needs them. We've got a few left in our office, but let me tell you, they're precious at this point. So they're that popular. So thank you for letting me do this. If you have Tidelands, we're sampling again in June, and would love to see your samples. It's not that expensive. I'll tell you, the shellfish growers really would like to use my deal with this lab, because their costs are 3 times this amount, and they have to pay a shucking fee. So it's only $25 to test for fecal bacteria and $30 for Vibrio. So from shellfish, so either clams, oysters, or gooey duck or 2 if you'd like. But most people don't want to submit gooey duck for this.
There's something extra special about the oyster industry having to pay a shucking fee.
Yeah. Well, it has to be, you know, a special check, so. All sterile.
Very good, thank you. Anything else come before the board this afternoon? Not entertain a motion to adjourn?
I move we adjourn.
All in favor?
Aye.
Good productive meeting, thank you.